Okay, well, it's now 1:02 p.m., so I think that I should get going. And I want to first of all thank all of you for joining us. And my name is Chester Ho. I'm a professor in spinal cord injury research chair at the University of Alberta, and also AHS Edmonton Zone Interim Zone Clinical Department Chair for Neuroscience, and Senior Medical Director of the Neuroscience Rehab and Vision Strategic Clinical Network. I'm really happy to be here today to share with you the findings of our research team's scoping review on the models of care for spinal cord injury around the world. And I also want to thank the Concentric research team for asking me to speak today. So my two objectives today are to share the scoping review results on international models of spinal cord injury care from rehabilitation to community, and also to discuss the lessons learned from this review and how they can potentially improve the transitions of care from rehabilitation to community in Alberta. When I say Alberta, I think that these lessons actually can apply to different provinces and different settings. Want to disclose that basically there's no financial conflict of interest, but there's one grant funding that's related to this project, but it's separate, and that's a CIHR grant, a team grant that we have for the Concentric model, a new transitions in care model for spinal cord injury. And so that is a separate project, but related. Okay, now this review was published in the Journal of Neurotrauma, and it was just published earlier this year, and you can download that for free from the journal website. And it was made open access by generous funding from the Praxis Spinal Cord Institute. I want to acknowledge my co-authors because it's not really just my work, it's our whole team's work. And just very briefly, they come from multiple institutions, and Kayla is a research associate from W21C at the University of Alberta, and Vanessa, as well as Joanna and Charlene are from the Praxis Spinal Cord Institute. Nicole is from AHS, and Lauren is basically the postdoc of Dr. Gilcher, who's a senior author from the University of Toronto. And Heather is our wonderful librarian from the U of C, and that's our mighty team. So I want to acknowledge all of the hard work on this project. Now, just very quickly for the background here, why are we doing this review? So, you know, I'm sure that many of you know all of this background already, so I'll just go through this briefly. There are about 86,000 Canadians who live with a spinal cord injury. And the estimated lifetime costs in 2011 dollars in Canada are basically $1.5 million for people with paraplegia and $3 million for people with tetraplegia. I think that that's actually probably, you know, an underestimate, because these are the direct costs, right? These are not really counting about people's loss of, you know, potentially a loss of work productivity, and also other indirect costs such as cost of care from their family members or other caregivers. And so I think that the actual cost would probably be much higher. And if you look at the total annual direct and indirect costs for Canadians with new traumatic spinal cord injury, it's about $2.67 billion every year. So what we are seeing is that it's a relatively small population, right? Comparing to people with stroke, diabetes, and other conditions, but it's really high cost. And so we need to really look at this care model to see how we can be very effective and deliver the best care and yet be cost effective. So we know that there are accreditation standards for acute and rehabilitative care for spinal cord injury. There are standard practice guidelines and also spinal cord injury research evidence. But there really is no current standardized model of spinal cord injury care at the provincial, federal, or potentially international level to guide us as to how we should deliver this care. And that's why we wanted to look at what the literature is out there, and so that will give us the evidence as to how to move forward. Now, what does it really mean then? Because that paragraph was just a bit abstract, right? So that means that right now with the current state, SCI care may differ between hospitals in the same city. And it may differ between geographical areas in the same province. It may also differ between provinces. And that the SCI care delivered may or may not be cost effective. So think about that. If you're somebody with SCI, how would that actually, affect you? If you're somebody who is a care provider for SCI, how does it make you feel to think that your care delivery could be different depending on the setting and the facility and where you are? And if you're a policymaker, what does it make you think? How does it make you think, we should be doing it? So let's go through it and then we'll find out more. And basically, right, the bottom line is that we want to find out how we're doing so that we make sure that we deliver the right care at the right time, at the right team, and at the right place. That goes without saying. And given that there was no previous such review in the literature, that's why our team wanted to do this work. Now, as I mentioned, this project aligns with the work of the Concentric project, but it is a separate research project with separate funding and a separate team. But I want to acknowledge both teams' effort. So what's the methodology here? Basically, we follow the 6 standard phases for scoping review. So we identify a research question, and then we identify the studies relevant to this question. We select the relevant studies and then extract data, and then we combine, summarize, and report the results, and then we consult with stakeholders. So what's our research question? Our research question is, what models of service delivery specific to the rehabilitation and lifelong care of persons with SCI exist internationally? And our objective was to describe the types of services and identify how these services are delivered to persons with SCI during the rehabilitation and community phases of care around the world. And I will just be brief here with our search strategy. We basically search these databases here, and we use search terms and subject terms which were related to the care model of care for spinal cord injury. And we looked at articles between 1995 and 2020. So it's really a full 25 years. So that's quite extensive. And we looked at articles outlining the formation of SCI care plans, lifelong management, community integration tactics, community mentoring, and transition programs. They're all included. And we also included gray literature from countries that are economically similar to Canada. So basically, we looked at the high-income countries according to the WHO definition. And I want to basically explain a little bit as to what gray literature means. That means that they're not peer-reviewed literature. They are published, in the journals, but they could be, policy documents from different countries and things like that. So those are important to look at, and you'll see why in a moment. So let's go through our search results here, and I'll show you the flow diagram in a moment. So we basically found over 10,000 articles from the peer-reviewed database search. And we reviewed 184 in full text after screening the abstract, etc. And then we, in the end, included 40 peer-reviewed articles and 6 gray literature articles. Now, in terms of the gray literatures, we actually searched 97 government websites around the world, but 49 did not have relevant results and 32 were unavailable in English. So this diagram here just quickly shows you, the whole strategy. As you saw, we started off with tons of articles, and after we removed the duplicates and then screened them, we were left with 184, as I said, and then in the end, there are 46 that were selected, with 6 gray literature articles, and then 40 articles from the peer-reviewed literature. Now, of those 46 articles. Like I said, 40 were from the peer-reviewed literature, and of those 40, 24 basically described the state of things in SCI care. So they just talked about how things are going right now. And then 2 of them talked about methods to evaluate models of care. And 14 talked about proposed models of care. And I'll go through those in a moment with you. And we found that 21 countries contributed to the literature. And if we look at where they were from, mostly they're from Australia. And you'll see why. Australia really has done some great job designing models of care. And the US came second, followed by Canada, and then the Netherlands. And I'll share with you what they are in a moment. So this map here just quickly show you where those countries came from, where we got the literature from. And they were represented by the shaded areas. So this is just a very high level summary of the results. Basically, as we suspected, there's no standardized model of care for SCI that's identified. Different countries have different models that they propose, but there's no standardized international one out there. And also, very interestingly, right, we always wonder, okay, we have these potential concerns and gaps in Alberta, but guess what? When we look at the literature, similar concerns were expressed by multiple countries. So we are not alone in this. And guess what? The gray literature actually provided the most information on several models of care. And we'll go through that in a moment. But despite these results, we actually found a few themes of the positive attributes for models of care. And so we'll go through that to see what we can learn from this review. So first of all, in terms of the descriptions of the stage of SCI care, we got a really important survey from a few years ago that was published in the American Journal of Physical Medicine and Rehab. It was an international SCI community survey that surveyed 19 countries, but actually Canada was not included in this survey. And they did a community survey with 19 countries all over Europe and the US, Australia, etc. And basically, a lot of people described that they needed to understand and improve their health and social needs, okay, participation and community reintegration, and return to work process for people after spinal cord injury. You will see that this theme of return to work comes up time and time again. And the need for development or improvement of vocational rehabilitation. And also some countries reported that they really wanted to have specialized spinal cord injury units. And that's an important finding. In terms of the methods to evaluate models of care, there are 2 articles that came from the Praxis Spinal Cord Institute as part of their Access to Care and Timing project in Canada. In fact, they designed a whole model that can take data from different spinal cord injury programs. You plug in the data, and then it can do a simulation as to what the patient flow may look like and what the effects are if you change one aspect of that patient journey, what are the downstream effects, etc. But as far as I know, despite the really good model there, I'm not sure that they have had the opportunity to really analyze any provinces data there. So I think we may have some opportunity there to take advantage of what they have achieved there. In terms of the current and proposed models of care, there are 14 articles, and they describe these models, which are summarized below here. There are 5 altogether. The first one is the transition rehabilitation models. These mostly come from Australia, from New South Wales, and from Queensland. And I really was impressed by how they are doing transition in care there. And we'll go through that in a moment. And Then the independent living model was also described by some people. This is versus agency care model. Now the independent living model really is similar to what we have here, self-managed care, right? Because we know that we do have that available here in Alberta, but at the same time, it's still limited to certain individuals. But guess what? This research actually found that clients who are under self-managed care gets more hours of care and better outcomes, such as better life satisfaction, better health outcomes, and lower costs. I think that's actually really good evidence for us to potentially, right, support more of this to be done here. Now, the third model is it talks about the inclusion of additional team members to the multidisciplinary team, because as we know, the traditional multidisciplinary team consists of nursing, allied health, medical team members, etc. But more and more papers are now talking about peer mentors as being very important, and actually even talking about having peer mentors as part of the official multidisciplinary team. So that's a bit of a change in the model. So I think that we need to learn about that. And also the Netherlands use a transmural nurse, or this is their term, to act as a liaison between a rehab center, primary care, persons with SCI and the community to improve continuity of care and decrease severity of health problems. Guess what? To me, that sounds like a navigator. That sounds like, you know, a case manager to me. And so really good for them to have done that research in the Netherlands. And then the other two models, you know, telehealth. We use this here in Alberta, and so that's great. And also local support model. This model really just refers to the development of a spinal cord injury network between rural health professionals and SCI centers to facilitate communication and coordination between services to improve health outcomes. So I think that's, you know, that's also something that we should pay attention to. And those are like the current and proposed models of care from the peer-reviewed literature. But now I want to go through the gray literature, which I found was the most helpful and fascinating. So let's talk about where they are from. So they came from mostly these countries: New Zealand, the US, specifically the Veterans Affairs in the US, Queensland, Australia, New South Wales, Australia, and the UK National Health Services. And they are so good that I want to talk about each of them individually. So first of all, the New Zealand's, you know, a spinal cord injury impairment action plan. I was so impressed by this. They have a national forum to guide collective action for this work, and they designed standardized protocols that are shared between the spinal centers, because they have several spinal centers in New Zealand. And the framework that they designed basically have 8 objectives to guide action for change both nationally and locally. And I want to emphasize that because they recognize that nationally they have to, you know, think about the multiple spinal centers, right? But locally, because they recognize that each site has its own different unique features and needs. So it's not one size that fits all, right? So I really appreciate that. And so let's go through these 8 objectives briefly. The first one is to improve acute clinical outcomes for adults requiring acute SCI care. And so they are talking about how to reduce the time from admission to spinal decompression from 15 hours to 8 hours. I really want to give them kudos for doing this, because I think that's very concrete and very, you know, goal directed, right? And I'm impressed by that. And the second one is to decrease the time from injury to admission to rehab in a specialty center from 13 days to 10 days. Now, I thought 13 days was pretty impressive already, but they're trying to decrease that to 10 days. And if we look at the data from Alberta, the average wait time from acute care to rehab for spinal cord injury, according to our national data, for Alberta specifically, is 20 to 40 days. So some food for thought there. And I also want to say that, for Quebec as a province, they have actually determined that there's a zero-wait policy for spinal cord injury individuals to get into rehab. So if you have a traumatic spinal cord injury in Quebec, once you are deemed medically stable, then you will get into a spinal cord injury rehab program within 0 days. It is how it is. It is the rule there. Again, food for thought here. Now, number two, improving the outcomes for children and adolescents. So they have a pathway to optimize health and well-being outcomes there. And then improving information sharing. They have worked with the Rick Hansen Institute, which is now the Praxis Spinal Cord Institute, a few years ago to establish their national registry. And they're using that for quality improvement and research purposes. And then they also want to provide nationally consistent SCI rehab services and extend community-based rehab. So they want to make sure that the processes and pathways are standardized and transparent. And they also want to make sure that the rehab needs are met after discharge from the spinal units in the community, because they recognize that there are gaps there. And the next one is to review and align the Ministry of Health and Accident Compensation Corporation processes for access to equipment, housing modifications, and transport. You know what? These are nothing different from what we want to do here, right? Looking at housing, equipment, modifications, and transportation. Wow, very similar. But they have actually, got a plan to do this nationally. And they want to develop peer support services more. So again and again, you see the peer support thing coming up from the different reports. And then build health and disability workforce capacity. So they recognize that they have to build up the workforce with training. And also they mentioned about this National Spinal Study Days for the providers. And so that's great. And then they want to support improvements for carers taking a cross-agency approach. I thought this was the best because they actually are testing out how to have existing clients, existing caregivers, if they are in the community, right? They are already injured, but they need to go back to the acute care hospital for their acute care type of problems. So they're testing that out to see if they can bring their caregivers with them because they know their care the best. And so they are wanting to test this out and then evaluate to see if they can spread and scale this. I thought that was really creative. I want to give them kudos for really doing such an innovative program. So that was New Zealand. Now the next one is the US Veterans Affairs model. Now they call it the Spinal Cord Injury and Disorders System of Care. And boy, is this a system, because it is a very top-down approach. It came down from Washington, D.C., and they have a whole directive there. And basically, they direct that the whole system should adopt a hub and spokes model, and it's under this handbook 1176. If you have a chance, look at this handbook. It is amazing because it tells you that these 25 centers in the US, they actually have a standardized organizational structure, standard services, staffing model, and individual responsibilities and training for the hub sites as well as the spoke sites. Very organized and very top-down though. Now, they emphasize on the continuity of care, and also they integrate primary care into the system, which is really quite something. There's lifelong follow-up and specialty care at the SCI centers. So what does it mean? That means that if you have a spinal cord injury, you obviously receive your care initially in the SCI centers for your initial management and rehab. But then once you're in the community, right now in Canada, right, in most places, if not all places, if you need to go in there for urosepsis, for pneumonia, you go into the acute care centers, acute care hospitals, or surgery centers, where you may not necessarily be treated by the docs and nurses and allied health professionals with SCI training. So they recognize that to be a potential gap. And so they basically mandated that these individuals will be treated in the SCI center for their lifelong care. If you have urosepsis, if you have pneumonia, guess what? You don't go to the random acute care unit. You go back to the SCI center where the nurses, docs, allied health professionals are trained and are best at providing SCI care. Doesn't that make sense? So this is just a diagram to show you how they are covering that. So there are 25 centers, and the red squares are the spoke sites. And so let's say if you are a spoke site, a hub site in Seattle, you're responsible for these 1, 2, 3, 4, 5, 6, 7 spoke sites in not just Washington State, but also in Oregon, in Idaho, and also in, I believe that's Montana. And so they cover a large area. Just for a moment, imagine that, geographically speaking, that would be quite similar to Alberta, right? So could we do something like that? Again, food for thought. Okay, so as I mentioned before already, they give rehab care and also chronic complication management. Now, let's talk about the primary care teams, which are built into the spoke sites. The spoke sites basically are staffed by a social worker, by oftentimes an NP or a physician assistant, and sometimes also a physiatrist. And also then they have a primary care doctor there as well. And basically, they address people's primary care needs. And so with the hub site support, they give them specialty care, oftentimes through telehealth, but then the primary care needs are addressed at the spoke sites locally. And they do annual evaluations for preventive care at these spoke sites. And there's collaboration between the hub and spoke sites, and oftentimes there is like, site visits and also quarterly meetings between the hub and spoke sites. So it's very organized. Now let's talk about Australia. And this is another area, another country that has some really impressive programs. So let's look at Queensland first. Queensland has a statewide service. Again, right, you look at these programs, they're talking about statewide, countrywide. So I want to emphasize that. They provide lifelong support across the continuum. They have the Spinal Injuries Unit, or the SIU, and then the Transitional Rehab Program, or TRP, that provides community-based rehab and support in the transition from hospital to community. And then the Spinal Outreach Team, or SPOT, basically they provide a specialist outreach service to regions outside of the metropolitan areas. Now that's pre-COVID, and they I think they're on hold now. And also peer support again, right? You see that theme coming up again and again. And so basically, let's look at the TRP a bit here, because I think that's really important. They basically have these TRP houses, or TRP, let's talk about the TRP program. So this is actually part of the rehab program. Everybody goes through the TRP programs towards the end of the rehab stay. And so what does it do there? If you are, towards the end of the rehab program, you go to TRP, where you actually either go into this TRP house that is provided by the government at no cost. And if you're living 100 kilometers away from the SIU, then you go into the TRP houses where you start to do your self-care. You start to really get used to it, but still under monitoring by the SCI team. And so they say, yeah, it's kind of similar to what we do here, right? For day passes or weekend passes, but you now actually go and live there, but under the monitoring and support, and you still continue to have your rehab as well. if you are living actually, within 100 kilometers from the SIU, you go home, but you still get the rehab and the monitoring by the rehab team under the TRP program. I thought that's really quite something. And again, something to think about. And then if you look at New South Wales, it's also really impressive. I want you to actually go to the New South Wales, the Royal Rehab website for spinal cord injury. I thought it was so inspiring. I love that website. Please go there and take a look. I was like really elated when I saw that. And basically, they have, again, a statewide service, and they have 2 acute care sites and 2 inpatient rehab units. Doesn't that kind of sound similar to Alberta? And 3 SCI outpatient clinics, and also, again, outreach service. Now, the outreach program basically has 2 components, the Metropolitan Spinal Outreach Service and also the Rural Spinal Outreach Service. The Metropolitan one provides multidisciplinary goal-based support, education, and clinical interventions for up to 12 months post-discharge from a spinal unit. So it's a multidisciplinary kind of follow-up service, right, essentially, for up to a year. And then for the Rural Spinal Outreach Service, they basically link people living in regional and rural New South Wales with the Sydney-based spinal cord injury units post-discharge by providing rural clients with access to these specialist medical and multidisciplinary team review close to where they live. So you see that, for both New South Wales and also Queensland, they really put an emphasis on outreach as well. And I didn't really include it here, but also South Australia has something similar as well. Maybe not as elaborate as these 2, but also pretty significant outreach services. So I talked about those countries, so let's talk about the UK before we move on. For the UK, under National Health Services, they have 9 spinal cord injury centres in the UK. In England rather, I beg your pardon. And the emphasis is outreach. They do outreach a bit differently there as well. Their outreach, this is very interesting. They have an acute outreach program. So that means that if you have people in the acute care setting, let's say if you're on the general medicine unit, general surgery, or other programs in the hospital, the acute outreach service will actually provide consultation to these individuals in these acute care sites. And so, the team, the medical specialist, the rehab nurse, the allied health professionals, they will go to these individuals and provide consultations in these acute care settings. I thought that's really making sense, right? That really makes sense to me. Then there's also the community outreach component. And so I think that will be similar to what Australia proposed as well. There's lifelong follow-ups. And again, in this UK system, they mandate that people with SCI-related complications after discharge from the SCI centers will still be readmitted to the SCI centers for their care. So again, in Canada, we oftentimes talk about the SCI rehab unit, but here, no, they talk about SCI centers. You see the difference? Because the SCI centers are basically providing lifelong care to individuals with SCI, whereas our SCI rehab units only really, for the most part, take care of the inpatient rehab needs. So I think there's a big philosophical difference there that we may want to, again, think about. So after all of the review, I just want to share with you as to what I have summarized as to what the positive attributes are for SCI care. The multidisciplinary team composition, and so again, how about inclusion of peer mentors that's been mentioned in multiple places. Provision of lifelong SCI specialty care at SCI centers. Again, multiple places are doing that internationally. Then rural SCI services, transitions and outreach, hub and spokes model of care, and the role of primary care in SCI management, and also vocational rehab that is being brought up in multiple papers. So after we learned all of that, how does it apply here in Alberta? Now, as many of you know, we have a separate research project called the Concentric project in Alberta, which I'm also involved with, but with a whole different research team. It's funded by the CIHR team grant using a community participatory research approach to improve the experience and outcomes of persons with SCI from inpatient rehab to community. Now, stage 1 of the Concentric project basically identified the gaps in transition, and stage 2, which is now, aims to co-design and transition the transition processes with stakeholders. So, with the Concentric team support, and I want to thank especially Lei, the provincial coordinator for the project, and Rich, our master's degree student. Basically, we did a crosswalk between the results from stage 1 of the Concentric project and also with the results of the scoping review. So, I'll share with you what we found in the crosswalk, but just quickly with the Concentric project, for the stage 1 interviews, we had 22 persons with SCI and 27 stakeholders from multiple areas in the province. And with that, basically, 6 themes were identified, including managing healing expectations, access to services appropriate for SCI, client-centered care, continuity of care, education, and social support. These were the 6 main themes that were identified to be really important for transitions in care in Alberta. And the 3 themes in red are the ones that really align the best with the scoping review results. So let's look at these in a bit more detail here. So first of all, access to services appropriate for SCI. So we are talking about availability, suitability, accessibility, affordability, and utilization of resources, services, or programs here, right? So how does it align with the scoping review's results? Basically, you know, for these things that we mentioned already, the local support model, building the network for rural providers and SCI specialty services, and use of telehealth to increase access to SCI specialists. We do some of this already. The spinal cord outreach model, and also vocational rehab. I think we need to really think about that. And how to establish multidisciplinary outpatient follow-up, and how to improve accessibility of healthcare facilities. We're talking about, you know, GP offices or clinics where, guess what? They are not oftentimes accessible. They don't have a lift. The doorway may be too narrow, and the exam table could be too narrow and dangerous for people with SCI. So we need to think about that to improve access. And how do we incorporate primary care into SCI care models? And to that, I want to mention that there is actually a primary care clinic in Kitchener, Ontario, that has taken on that mandate already to incorporate SCI care in their practice, and they are publishing some really good results too. So if we look at client-centered care, so how does it align with the scoping review's findings? Basically, we need to increase consumer control over the rehab environment. And also, we talked about the independent living model, such as the self-managed care piece, and increase peer support. Like I said, I sound like a broken record now because so many different papers talked about the importance of peer support. And it's not just a proposed model. They actually have research evidence to support the importance of that. And then the continuity of care piece, and that's really important because we have a large geographical distance, right, between multiple sites in Alberta, just like it is in Australia, right? How can we do a better job there to provide better continuity of care? And how do we also prepare and equip individuals when they are transitioning from the inpatient rehab phase to the community for the realities in community, right? So from the scoping review, we need to think about how we really integrate the SCI system of care across the continuum. So we're not talking about just designing a program in this facility or at this site or here and there in parallel. We are talking about how we need to think about this as a model of care, as a system of care across the province, and even better, if possible, across Canada, right? Because how people do things or get care should not ideally be different, between provinces, let alone between cities within the same province. And how we want to think about, the transition rehab model and the outreach and inclusion of primary care, and then lifelong follow-up. We have started doing some of this already, like spinal cord injury annual evaluations and formal transfer of care at transition points. How do we do a proper warm handoff? How do we really engage the teams formally? And how do we actually utilize process mapping, right, to map patient flow and to really understand the whole, downstream effect when you change one thing at one point? And so I think those are things that we want to think about. So just to summarize, and now there's no internationally agreed that, and if you're not speaking, if you don't mind muting yourself, that'll be wonderful. Thank you. And there's no internationally agreed and standardized SCI care model as we expected. And several countries have really integrated statewide or national SCI models of care. And then there are some positive attributes of SCI models of care that we already went through. And in terms of what we can do in Alberta, the stage 1 of the Concentric project identifies some gaps in transitions of care, and we can really maybe utilize the results of the scoping review and also the results of the Concentric project to see how we can improve things in Alberta. So just final thoughts, I've mentioned this again. What are we doing well with our SCI models of care in Alberta and in Canada? I think that we have some great things here because we are one system in AHS in Alberta. So even just to try to implement, standardized models of care could potentially be a lot easier than in some other places. So think about that. And we have lots of expertise here as well. And what can we learn from the scoping review? And what are the opportunities that we have to improve our SCI model of care here? So once again, want to acknowledge our scoping review team here, and also the funding support from the U of A SCI Research Chair Endowment Funds, and also from the Praxis Spinal Cord Institute, specifically for this scoping review. Thanks very much, and I think we've got some time for questions.
Chester, this is Jim here. Can I ask a couple questions?
Sure, Jim, go ahead, please.
I was wondering from your review, and I love your talk, it was great and very comprehensive, very impressive. Did you get a sense that the different places were better able to provide better coverage of those with spinal cord injuries to the same level? I'm thinking in the US, for example, I've visited some sites for veterans, right? Military veterans that have great facilities. And I'm not convinced that they translate very well into the sort of the far corners of the country. And then you can't, in this day and age, separate financial sustainability from services. And did you have some thoughts on that as well?
Sure. So, Jim, thank you. Let me address your first question. In terms of the different models, I think that, when you look at the papers and the great literature, right, you read about it, but honestly, there's nothing that beats actual discussion with the different teams, and also even living through the different models, because I've worked in different places, including the US Veterans Affairs model. So you can really see the pros and cons that each model has. Like you say, in the US model, right, they may have very good coverage in some centers and some hub and spoke centers, but not all hub and spoke centers are built the same. Some do a better job and some don't. Now, some hub and spoke centers, as you say, have a really good relationship, strong relationship with the spoke sites. They do a fantastic job even covering the rural areas. But some hub and spoke centers do not have a strong relationship between the hub site and the spoke sites. Then they don't provide as strong support to the spoke sites, and therefore the people with SCI residing around those areas. So I think that your point is well taken, that even with models, the devil's in the details, right? You have to really think about it. Plus also, you see that all of these different models really have pros and cons. I think the best that we can do is to learn from the best of each model and then come up with our own model, having incorporated the best of everything. That's how I kind of look at that. And in terms of the financial sustainability, I think that we need to think about this in different ways. The first way is that some of these models actually rely on different funding, because they may rely on like the insurance funding. And so I don't think in Alberta we rely on that, but that actually turns out to be a pretty good source of funding for many places. And then the other thing is, I think that people recognize in some of these models that if you do this model of care, you are preventing complications, you're preventing subsequent health-related issues. And I think that in the healthcare system, it's so difficult to actually measure the cost savings for prevention. And so that's why sometimes it's difficult to convince people, right? But I think that people need to have that buy-in to really think that, okay, for this population, we really need to do preventive care by having a really concrete and very integrated model. So we're going to save dollars down the line, let alone, most importantly, that people's lived experience will be much enhanced. So I think that we need to think about things in multiple ways for the so-called sustainability.
Thank you very much, Chester. That was great.
Sure. Let me just see if there's any question in the chat box here. Can we share the PowerPoint? Yes, absolutely. Be happy to do so. And okay, any other questions or any thoughts from anyone? I think I want to see, maybe some, what are your, even if it's not a question, maybe your reactions as to what you think, after hearing about what other countries do for their spinal cord injury care model.
I
Dr.
do
Holt.
Chester. Oh, sorry.
Oh, sorry. Go
ahead.
First and then...
Who wants to go first? Mine's quick. I just wanted to say thank you, because I practiced in New South Wales for 25 years, and I saw a lot of those things unfold with the Agency for Clinical Innovation. One thing I will comment on is that Australia works within a two-tiered health system, and we have very robust, the hub and spoke models work very well, because a lot of the spokes can be private but I don't think that precludes us from moving in that direction. Models of care are very I believe very integrated and useful tools to ensure that a patient has, and particularly SCI patients and any other patient with any other chronic and complex conditions, that ability to have a quality of life that is, can often be not be present without that support. So I just wanted to thank you and reminisce there for a little bit.
No, thank you, Anna, for that really great insight, because as I said, right, I think that each model has its, unique areas, and it really pays to talk to the people who live through that to understand it better. So thank you for that.
No problem.
Dr. Ho?
Yes.
So
Hi, Edgar.
having heard all that and the great presentation that you did, thank you very much. what are your thoughts on our next steps moving forward to integrate the most positive parts of this study into the system that we have here in Alberta? How would we go about doing that, and what would the scope of work and the tasks that we'd have to do to implement all this to make our system be improved?
Thanks, Edgar, for that. I think that right now there are lots of different groups working really hard already in Alberta to try to improve the care, right? I know that people with lived experience have already formed different groups to really try to do it in a more grassroots level. And the nursing staff, have done some really great work recently looking at SCI nursing care across the different centers and how it can be improved. So I think that's really good. What we need to do, I think, is the following. We need to really pull the different groups together. And also, I think that learning from these models, right, they all have a very organized kind of structure. And so I think that we need to have some sort of provincial steering group or something like that to look at how to pull the different groups together to form, to look at the SCI model of care. Now the concentric model is looking at specifically transitions in care. There's a big piece there. I think that we can build on that work as well. And so I think that if we actually can get the systems buy-in to really look at this in a systematic fashion and then incorporate the different groups' expertise and existing work to leverage on what they have achieved already, and then learn from the scoping review and also incorporate the work of the Concentric team, I think that would be really amazing.
Yes, thank you.
I'm seeing some comments in the chat box, and thank you for your comments. I see that, I appreciate your comment. And you say you like the term cross-pollination. I think that's so important because we really can learn from many different places and even among ourselves, because we have a lot of talents across the province here with lots of people doing great things. We just need to come together and have more cross-pollination. And Don, thanks for your comment. And the hub and spoke system and the transitional handover, those are all really good things. And Vanessa, oh, thank you. And Vanessa and the Praxis team have really provided unbelievable support to actually get this scoping review, through the finish line. So really appreciate that. And as I said, the scoping review is downloadable for free as an open access article, thanks to the general support of the Praxis Spinal Institute. So thanks, Vanessa and team. And Bean, thanks for your comments. I think that we need to really leverage on the, very excellent enthusiasm from the stakeholders from multiple areas. And so I think that the time's right. And I think that with all of these different pieces, we can all come together and do a better job altogether for people with SCI. And Vanessa's comments that there's work being done in other provinces, so it would be great to have a national advisory group as well to share experiences. I think that would be fantastic, Vanessa. And I think we talked about, okay, perhaps we should do like a white paper, right, on the ideal SCI care in Canada, and maybe with the different groups coming together, we can consider that as well.
Thanks, Chester. It's Vanessa. Would love to help. Anything we can do at Praxis. So exciting to see all the great work being done in Alberta, and I think you're right, the timing's right.
Thank you. Oh, and I have a comment from Dr. Chima in Pakistan. Well, thank you so much. My goodness, it must be like after midnight your time there, and really appreciate it. And I know that we have also Sijana, who is going to start doing her master's degree with me after the new year. She's now in Nepal, and she's also here today as well. So thanks for joining, Srijana. Srijana really is interested in this model of care work and registry work. So she'll be working with us after the new year. Okay, well, if there's no other question or comments, it's just gone 2:00, and I just really want to thank all of you for attending. And you know, this is a very important presentation for myself, because it's what I really love doing, and it's my passion, and I just love that I can share it with you. And I really appreciate all of your enthusiasm and how, you know, we can all work together to improve the care for all the services for people with SCI. It's not just the care, it's the whole package, right? The whole service package. So thanks very much again for your attendance, and look forward to working with all of you.